Good morning. Hope all those online can hear me. So welcome. It's my pleasure to introduce our guests today, but before I do that, I just want to say one quick thing. Today's and last week's lecture by Dr. Henschel are both considered faculty development. And for those folks with faculty appointments at VTCSOM, you're required to have 2 credit hours of continuing medical education around faculty development. So this counts. So if you were there last week and if you're here this week, the way it counts is for you to fill out your evaluations. So you have to go online to the appointment and click on all that and fill out those evaluations. And I think Vicki has expressed to me that she's concerned that a lot of people are not doing that. I know I'm guilty of not doing that all the time. But please, last week's and this week's, and for the residents, you don't need to do that, but for the faculty, you do. So it's my pleasure now to introduce our guests, and I don't have their CVs. I'll try to get this halfway right, but Dr. Vydia Permashwar is our clerkship director for our 3rd-year medical student and 4th-year medical students as well. Vydia grew up in Jamaica, in Paradise, and went to school in the Caribbean and practiced in the Bahamas. I mean, that's just wonderful, right? Before coming to the U.S. And then she completed her pediatric residency at Detroit Medical Center in Detroit, Michigan. It was Michigan Children's Hospital. And then Dr. Emily Nguyen dropped out of the sky a few years ago, miraculously. I was never so thankful for that call. And she's one of my partners in pediatric hospital medicine and has been here for about going on 3 years, right, Emily? Yeah. Is doing a great job, but she's a assistant clerkship director. So Vydia, Dr. Permashwar, and Dr. Nguyen will be giving us an update on medical school.
Hi, good morning, everyone. Welcome to Pediatric Grand Rounds. I can't not stand here and say welcome to Pediatric Grand Rounds. All right, so I'm Dr. Permashwar, that's Dr. Nguyen. So today, our objectives at the end of this presentation will just be to outline a little bit of our core clerkship curriculum, review some of the upcoming changes, and for our faculty development portion, we'll talk a little bit about health system sciences, what it is, what it means for us as we navigate forward. We have no relevant conflict of interest to declare. So who's who? I want to just say a very special thanks to Janie Woods, who was our clerkship coordinator for many years and has moved on to VTCSOM. Big thanks to Nikki Hedrick, who has stepped up in the last few months as our interim coordinator, and we look forward to working with Megan Fouts, who hopefully will start very, very soon as our clerkship coordinator. So fun facts, we usually do fun facts when we introduce ourselves at orientation. So my favorite subject was actually geography, and I really wanted to be a traveling biozoologist, geologist. I think I still have a few years to get that goal accomplished. Dr. Nguyen, surprisingly, once won a free t-shirt for eating an entire XXL pizza in one sitting. You cannot tell by looking.
Did you eat the t-shirt too?
I think I still have it. It was a long time ago. So a little bit about our pediatric clerkship requirements. So we utilize a few different things to teach educational goals. We do directed observations, which is a specific real-time feedback on some clinical skills. And we ask them to do 1 a week, but we'll accept 4. It does not have to be an entire patient encounter. It is really, think of it as tips and tricks that you would like to learn. How do you examine hips? How do you examine HE&T? Things that communication, things that you require for the rest of your journey. It's not specific to pediatrics. They are asked to write and review with a resident or faculty a singular H&P that's graded on a rubric. We encourage your attendance at all of our clinical and academic educational activities within the department. We have specific student didactics or facilitated discussions once a week, usually on Wednesday afternoons or Tuesdays, from which they are to be excused from their clinical sites. Other than that, they are not excused from their clinical site unless they have a specific excuse from their school and us. We have 3 virtual noon lectures per block, which can be done virtually unless they are in site. Grand rounds, case of the week, journal club, which can be attended in person or virtually. Morning reports, when they are on the inpatient team, pretty much tell them, you do as the team does. It is not mandatory if they're not on the inpatient services, because many times it interferes with them getting to their rotation sites on time. We do orientation for all our students, a mid and an end of clerkship feedback session. They also are provided with aquifer cases, which used to be called clip cases in the past, that they may use. Mandatory, we request 10, 1 being a social determinant of health case, but they are asked to utilize all the resources that are provided. The VTCSOM students have a national NBME exam at the end of their rotation, as well as an OSCE or clinical skills test. So the basic structure of our curriculum is designed to showcase the breadth and depth of pediatrics. So we do try to get a good mixture of inpatient and outpatient. VTCSOM has a 6-week clinical rotation. We try to get 2 weeks of inpatient, 2 weeks of outpatient, a week of nursery, and an elective that they have some choice in. VCOM and the Radford PA schools rotate for 4 weeks. And we also try to give them a little bit of an inpatient-outpatient mix. Thank you very much to all of our elective directors in cardiology, GI, endocrine, hematology, neurology, pulmonology, for designing curriculums which our students can be exposed to the different specialties. And to be clear, at this point in time, all students from all schools are allowed to see COVID PUIs and COVID positive patients if they wear the correct Carilion approved PPE and are vaccinated and boosted. So our clerkship evaluations, VTCSOM, which is our primary school, they review us based on 4 main categories, and that has been consistently good, with a slight bump in the clinical experience scores of recent. VCOM usually scores us highly, and the PA schools as well, 4.9 out of 5. So I think overall, we strive to improve as always, but things are pretty good at this point in time. What are some of the recent and anticipated curricular changes? So we've decreased, with feedback, the mandatory amount of aquifer cases that we ask our students to do, and we've been gradually decreasing from 30 to 20 to 10. I've been asked to and included some specific HSSIP activities and some of the mandates from the Diversity and Inclusion Task Force. We've also, for the first time this year, been able to offer students to practice NBME tests that's supported by their school if they wish. Anticipated changes to come. The class size for VTCSOM, as you know, they've been in a process of expansion, is paused as of this time. So we will continue to be expected around 49 students for the next year until further strategic development that allows for expansion. We will continue to take the same numbers of VCOM and Radford PA students as we always have at this time. The traditional grading system in the past, we were a pass-fail rotation with the possibility of letters of distinction, will be changed to the more traditional honors, high pass, pass, fail, with actually this current group of students that are rotating at this point in time. So I'm going to pass over to Dr. Nguyen, and I'll be back a little bit later.
Alright, so the larger context of this change to the grading system is step one, of course, moving to pass-fail instead of getting a specific grade. So there is a little bit more emphasis on how do we evaluate students within medical school and then as they apply to residency as well. I will say another part of this context, as we've been looking at what other medical schools are doing nationally, there is somewhat, I would say, anecdotally at least, of a trend moving toward in the other direction from traditional grades to pass-fail. So it's just, I think, an interesting time. The other reason, I think, larger reason that Virginia Tech has made this change is feedback from residency programs. So it can be really hard to interpret, well, the clinical grades are pass-fail, what do letters of distinction really mean? And as you can imagine, for very busy residency program directors, it can be very confusing when so many different schools have so many different grading systems. So this was a move to make it a little bit easier for that evaluation process. So like Dr. Permashwar said, this actual current block will be the first one, block 2, to have the traditional grading system. Previously, it was pass-fail, and that includes block 1 of this year, with the opportunity to achieve a letter of distinction. There's been a lot of discussion, both with Dr. Permashwar, myself, and really the larger medical school on how do we come up with a grading system. And that's what we have here that you're looking at. So you'll notice that the biggest percentage comes from clerkship assessment of students. That means clinically, how are students doing and taking into account residence and attending evaluation. And the second largest is the exam. The thought was that ideally that is an objective measure, and so trying to balance the subjectivity from clinical assessment, which of course is incredibly important, but does have some subjectivity to it, as well as the theoretical objective nature of the pediatric exam. And the OSCE is something that is, it's a standardized patient encounter that is specific to pediatrics, and that makes up 10%. So this is not a bell curve, this is not graded on a normal distribution, and there are minimum scores on the exam to be able to achieve honors specifically. There was also a lot of discussion about professionalism. So, of course, even if students do really well clinically, maybe they really impress the certain attendings, they do incredibly well in the exam, if there are any professionalism issues, then they cannot be eligible for honors. So that is something that, of course, we take very seriously. So this goes over in a little bit more detail. Again, the clinical assessment is considering all attending and residents, as well as resident feedback as well. And so I think sometimes residents, they're so involved in the education of our students, but they sometimes are left out a little bit in terms of the actual evaluation. They have such rich comments to be able to provide our learners because they interact with them so closely, at least on the inpatient side. So definitely encourage all of our residents to, if you feel strongly about a student and their abilities, definitely let the attending know, and you can actually fill out a formal feedback evaluation as well. And there's, it's done on 145, there's 5-point rubric on a number of different items that are all tallied up. So especially with how much weight is given to the clinical assessment, it's incredibly important to make sure that we're thinking very deliberately when we're assigning those grades for our students. And on the NBME exam, that chart is just to show that our students perform very similarly to the national average. And like Dr. Permashwar said, this year we actually do provide our students to have access to 2 of those NBME practice exams without a fee. VCOM is a little bit different. This is just a reminder that their evaluations, they go from honors to fail as well. And if you'll remember on the actual evaluation sheet that is often printed out, the middle kind of 3 that you think of as average actually equates to a C grade. So just keeping in mind what those actually mean when you're filling those out for VCOM students specifically. They do have the additional opportunity to earn Distinguished Scholar nominations. So there's a tiny little box hidden there. So certainly if you're really impressed by one of our VCOM students, check that off and let us know so that we can keep track of it as the year progresses. And all comments on evaluations will be seen by students, so just be cognizant of that fact when you're writing the descriptive evaluations. And those may be included on their MISPE as well when they're applying. This is a reminder, Radford PA is very similar to the BCom students, where 3 equates to a grade of a C. So professionalism, this is just, again, a reminder to be deliberate in teaching the hidden curriculum. So those are those kind of implicit things that we don't necessarily directly say, but things that our students observe us doing, and modeling professionalism as well. Students are always listening. I think there is a tendency, you know, as a clinician, all of our jobs are incredibly hard, and sometimes we make jokes or make light of certain situations sort of as a defense mechanism to kind of get through some difficult situations, but just be mindful that our learners they're like sponges. They're picking up on all of the language that's used, as well as the culture that it creates. We did want to comment that we have received both formal and informal complaints about the learning environment, which is why we're talking about this. And actually does seem to be, for what it's worth, more than what we have received in the past, as well as compared to other clerkships as well. So just something to be mindful of. And on the flip side of that, it goes both ways, right? So if you do have concerns about a student, particularly with professionalism or with lower than average evaluations, please let us know. This has definitely come up within the past year, and it's always better to know about it earlier on so we can address it and remedy it with the student. And again, that goes for residents as well, because you work so closely with our students. And then final reminder to not excuse students from clinical rotations without approval from their respective schools. This is a little bit of an overview for our students who are interested in pediatrics. Last year, we had 2 students successfully match into pediatrics and med-peds. And this year, we have actually more than doubled that, 5 VTCSOM students interested in applying and 20-something VCOM students interested in applying to pediatrics. Bit of a plug, we have an Applying to Pediatrics panel in August. The tentative date is August 16th. But we'll send out a reminder to faculty and to residents to help discuss with both VCOM and VTCSOM students any questions that they may have, some advice in applying. The application cycle will be virtual again this year, and there's something new called, not to get into it too much, the supplemental application, which allows applicants to go in a little bit more detail about some experiences that have really factored into their journey, as well as identify certain programs that are of specific interest to them. So this is my favorite part of the presentation. I wanted to thank everybody for all faculty, all residents for their teaching, especially to some that I see in the room, Dr. Chemez, Dr. Doherty, Dr. Stewart, Dr. Borowitz, for helping out with specific didactics and taking extra time to really teach our students. And then, of course, all of the residents who factor so heavily in the education of our students and our learners. We've gotten some really wonderful feedback that I wanted to share with everybody from our students. So, great pediatric population with plenty of diversity. My favorite rotation of medical school. I felt like I was a contributing member of the healthcare team, walking out of this rotation feeling so much more confident in my ability to be an effective doctor than I did going in. What really made the rotation special was the people. I cannot speak highly enough of all of my attendings and residents. I've never felt more valued, more welcomed as a member of the care team, and struck by the fact that everyone that they worked with were genuinely happy, even on busy days. So that is just a reminder and a thank you to everybody for all of the work that you do, especially when you're busy clinically in teaching our students. And moving on to the Pediatric Resident Teacher Award. So this is nominated, voted on by the students. We don't really touch it. We tally up all of the nominations, and it's meant to be for residents who demonstrated the greatest interest and who were the most effective in teaching and precepting medical students and PA students during the pediatric clerkship. So it's from all of our learners. So the first one, I took some quotes from the student evaluations. This person was the best resident physician I have worked with, was so welcoming and an incredible teacher, would always push our thinking to the next level. This person deserves an award and went above and beyond in their efforts to help me learn, should be commended. So this first one goes to Dr. David O'Neill. So congratulations to him. And then the second one is some comments include one of the best overall residents I've worked with, the true superstar resident on the basis of how much empathy and willingness to teach and love for others that this person has. I'm definitely a much more confident and knowledgeable student doctor after working with this resident. And this one goes to Dr. Leah Birdwell. I believe this is the first time that it's gone to 2 interns actually, which is incredible. So big thank you, congratulations to Leah and David. So before I move on to the faculty development portion, any questions about clerkship organization or anything that we've talked about thus far?
The number 20-ish students from VCOM, is that students that are actually rotating through here, or is that just total per their class?
I believe that's total.
That rotates here.
Really? That's a very large number, so okay. That's good.
Oh, no.
I believe- I think it's
that
the
are
whole
applying
school,
pediatrics.
yeah.
It's
From
whole
the
school.
class.
I'm sorry.
Okay.
The OSCE portion of their grade, what input does the Department of Pediatrics have on that? Like,
Currently, good question. Currently none, but that is about to change so that we can prepare our students a little bit better. So we're in talks with Dr. Lane at the medical school, and I have spoken, so I understand a little bit better, and moving forward, we'll be a little bit more involved in selection of cases.
Traditionally, I think the students do very well on that portion.
it just strikes me, do we have a pediatrician even observing any of that? Because we're the pediatricians, right? Yeah, but we don't, okay.
But from what I'm told, it's very similar to their standardized patient exam that they get at the end of the second year. They're not walking into pediatric patients. It's just a standardized patient that, and the topics they've selected are bread and butter pediatrics. It's not anything weird and wonderful, I'm told. Yes, Dr. Smith?
How are we getting communications about students who are going to be out for specific reasons? I know we get communications about the rotation. Sometimes we'll get notification that they might be gone for a specific activity, but unplanned or other, who communicates that?
So it depends on what they're being excused for. For the typical lecture schedule, that should go out every block as far as, and it can, honestly, it can be hard to interpret. The big thing to know is they're only leaving their clinical rotations for the afternoon kind of didactic session, which you do one of, but everything else should be, can be virtual. As far as the excused absences that have to go through their school, that should be emailed out ahead of time.
Or for illnesses, which we can't predict, by the clerkship coordinator. It does sometimes happen that it's a little bit after the fact, but we do try to keep you informed.
And then VCOM specifically for those times that they're pulled out 1 or 2 times a block, I believe that should come from, we can clarify that one, make sure that we're sending that out if someone else does not.
They have some women workshops and some student presentations they do, but it's not often. It's an hour or 2, maybe once every few months that happens.
Dr. Kreider would like to know, how do you take all of the evaluations and compile a final grade?
So with each school, we have a different evaluation system. So the 145 does it for us. So we click in as many as we try to get a 360 evaluation, and it creates a composite. It averages out, and I send that on to the dean.
And that's VTCSOM.
That's VTCSOM, and the same is done for VCOM. So it is an average of what everybody puts in. At this time, there's talk, but there's no conclusion on do we eliminate the high and low and just go with the middle, but it is an average. So if somebody is scoring very high, but another person is scoring their sort of average, that is what it will end up being someplace in the middle.
I was just going to mention that we may have not communicated well to you and the students, and I apologize for that, but morning report is also being done here live now. So we're live grouped into the hospital. So we do sit in a room to do that. So I'll make sure that you guys get the room number so the students can come join us here at Tanglewood as well.
Thank you. All right, well, we'll move on. All right, so today we are going to talk about a little bit about the concepts behind health system sciences, development and introduction. So first question. In 1910, Abraham Flexner visited all the medical students in the US. What was the dominant form of medical education at the time? 1, dissection and quizzes in the morning, hours of lectures and reading in the evening. 2, long hours in the teaching hospital, reading at night. Or 3, apprenticeships with veteran physicians and scanty formal training. What do we think? Scattering of all, but mostly 3 at that time. So hopefully we've come a far way in our medical education curriculum. So what is this topic of health system sciences? It is pretty much just a foundational platform and a framework for studying and understanding not just diagnosis and therapeutics, but how the care that is being delivered, how we work together, how we collaborate, and how the health system can improve direct patient care and healthcare delivery. So, quote unquote, it's the principles, methods, and practice of improving quality, outcomes, and the cost of the healthcare delivery for our patients and populations within the system of medical care. And it moves us in a slightly different direction towards a new professional identity as a system citizen. So moving away a little bit from the individual to the more systems and broader thinking as we move along. And you may say, well, is this just a fad? Is this just the newest buzzword that you're asking me to learn and adopt? So we looked at pretty much 100 years of data as we've moved along. So Flexner in the very early 1900s released his report on quality, safety, the structure of our curriculum. You know, we added in the humanities in the 1980s. We've had multiple milestones. Institute of Medicine reports that focused on errors in the medical system, healthcare disparities. We've taken that and introduced it into our curriculum. AMC has focused on the social aspect and how that affects the delivery of healthcare and the presentation. And so in 2015, they coined the term or the terminology of health system science, and that has taken off in fairly recent years with textbooks and modules and training courses. So you may ask, well, it's just quality control or safety. It includes quality, but it is not quality. It's a much broader framework that we are taking away to give a broader perspective and create the system thinkers that we are for future generations. So this is the lovely wheel that you've probably seen around, and it is just a conceptual framework. So at the very center for everything that we do is patient-centered, family-focused, community-responsive care. And so the first concentric circle around that core are the 6 core domains that affect healthcare delivery: population and social determinants of health, value in healthcare, clinical informatics and health technology, healthcare structure, healthcare policy, and healthcare system improvement. And so around that, the circle, those are the linking domains, the knowledge, the attitudes, the skills that connects us all. How does the leadership frame this delivery? How does teaming, interprofessional collaboration affect that? How does our attitudes towards change management, advocacy, ethics, legalities affect the way we deliver the healthcare? And around the entirety of that is the move away from an individualistic approach to healthcare to a broader systems thinking so that we can improve population health as a whole. And so, you know, you may think, well, that's just too much for me. I don't understand what any of that is. But we're going to play a little game of have you ever, and then you're going to relate it to that pretty little wheel on the left. So just a show of hands, have you ever taken a social history in your life? Yes. Where does that fall into our wheel? Yeah, oh, we're doing 5 o'clock. Okay, social determinants of health. It's like, where's 5 o'clock? Have you ever paused for a second as you're about to prescribe any medication and considered the cost of the medication? Is it covered? Do they have insurance? Yes. Where might that fall in? 3 o'clock. Value in healthcare.
Piece of healthcare policy and economics as well.
And it doesn't fit one. Many times it interacts with different. Have you ever consulted a pediatric guidelines and when to start phototherapy? Use the lovely Normogram or Billy Tool or the newest one on Epic? Yes. Where might that fall in? Informatics. So we're using technology. We're using guidelines which are based on review and research. Have you ever placed a referral to social work, Care Connection, used your care coordinator in office? Where might that?
Upper left.
Upper left, okay. Healthcare structure, process, yes. Have you ever wondered why your asthmatic patient keeps going to the ER 6 times, but has not once gone to see the pulmonologist or their primary care specialist? And what might that be reflective of on our wheel? Many things. So it may be social determinants of health, lack of access with our healthcare system or structure. So these are things that we're already doing. Have you taken that one of these lovely VMAP state-sponsored courses that addresses mental health disparities and the pandemic that we're currently in? Yes, we've taken that. And what might that be a reflection of? Maybe advocacy and a reflection of the current pandemic and need for improvement. So you're actually doing health system sciences. That's what I want you to take away from this. And just a little plug for social determinants of health. VTC is rolling out in the clinical forum that every department sort of owns one of those little subsections. And for the Department of Pediatrics, our core domain of interest that we will focus on clinically will be the social determinants of health, population health, and public health. So again, as you probably already know, it's everything. Where we are born, where we grow, where we age, where we're educated, where we live, where we work. And so we've got a wide variety of things that factor in up to 80% of our healthcare prevalence, presentation, and outcomes. So why? Why do we need to learn about health system science? Why do we need to teach it? Why do we need to model it in our clinical, in the clinical exposure? So a wise person said, and it was not a pediatrician, unfortunately, we will never transform the prevailing system of management without transforming our prevailing system of education. They are the same system. They are not siloed. You cannot expect change from our learners if they're not educated in the system in which they're about to become a part of. And it's been recognized for many years in the GME world that our residents coming out are good at what they've been trained to do. They're good at making diagnoses. They're good at doing therapeutics. But do they have all the skills and knowledge and education that they need to navigate our health system on behalf of patients? And they realize that their education may have been lacking somewhat. And the overarching goal of health system science education and the push at this time is to help our future clinicians understand the great interconnection, not just of the biopsychosocial model, but of the systemic perspective and processes that goes into the delivery of healthcare and helps them to feel empowered to make and implement changes moving forward. And it has been adopted as the so-called third science or third pillar of medical education. Most of us trained in a two-pillar system, basic science for 2 years, clinical science for 2 years. But they've added in synergistically the education of the science of the health system in a hope that this triple pillars or the triple sciences will have a greater impact on the quadruple aim of healthcare, which is, at the end of the day, improve patient outcomes, improve clinician outcomes, improve the patient experience overall, and while, of course, doing it at a lower cost or keeping value-based care in mind. And I think we've all thought that sometimes, what we do every day on an individual basis with our patients, it's important, but it is just a little tip of the iceberg. And there's this giant web and maze and murkiness that we have to navigate on a daily basis, for which we've many times received very little formal education. It's many of the times it's just learning on the job training, learning the hard way many times. So with research, what they've realized is our students and our future clinicians need early and continuous longitudinal immersion, clinical experience into an exposure to health system sciences in order to gain competency in these skills. They're not mastering it, but they're being exposed to it so that in future they can manage effectively patient care and be involved in care transformation of the future. And so with this comes a shift in the mindset or the paradigm of what is medical professionalism. And Dr. Gonzalo is one of the leaders in health system science, literally wrote the textbook, and incidentally will be joining the VTCSOM faculty, I think, very soon. And he relates that, for physicians, it's not just about being good, respectful, altruistic, trustworthy with our individual patient care, but it's also about their relationships with the healthcare system and being in a symbiotic relationship, being a steward and being an ambassador of healthcare resources. And that requires a mind shift switch that addresses some of the challenges and the insufficiencies in our healthcare system, and sort of putting a lens of responsibility on the part of the future physicians to address some of these or change some of these or have the ability to change some of these issues. So what are some of the barriers to potential implementation of a health system science curriculum with a broader lens? Well, who's going to develop the curriculum? Who are the leaders? Who is going to be guiding us? Does that exist? What is our basic understanding of the health system sciences? The curriculum is already packed. Where are we adding in one more thing at every level, undergraduate and graduate? What is the buy-in from leadership at every level? Are they supportive of health system science and the divergence into that realm? And not every physician wants that paradigm shift to be responsible for the bigger picture of healthcare. I'm okay in my box. I do what I do. I'm good at it. I'm okay as an individual. I'm doing fine. I don't need to worry about what happens next or what happens in the future. How do we get students to buy in that these are important skills that they need to learn at this point in time? How do we get faculty to buy in that these are important things that we need to teach and model? What is their comfort level with the subject matter that we are asking them to discuss? And some of the strategies that have been discussed with addressing the faculty component of this engagement and skills is, of course, faculty development, education on the concept, improving their understanding and their expertise. What I really want to say is this is not anything new. This is what we do on a daily basis. And we've been trained to do, and we've learned to do through our experience. So we grab every opportunity to label HSS content. Just like we did with the wheel, what we do organically, holistically, reflexively for our patients. Frame it as a new responsibility, this new professionalism to hopefully get some buy-in. But there are going to be barriers and there are going to be challenges. And from a student perspective, you know, they came in with a two-pillar model in many cases. Their focus is on grades, passing exams, getting into the best residency possible. And now maybe there's a mind shift change in that it's not just about passing the exams, because you still have to pass the exams, but it's about learning additional skills and becoming the best doctor possible overall, and not just getting into the best residency. So for VTCSOM specifically, they have adopted the health system science as their third pillar of medical education. So our current group of rotating students are the first cohort that have been trained for the past 2 years in health system sciences. And they are part of this longitudinal curriculum over the course of 4 years, for which health system science will be introduced and taught at every level. Again, the domain of focus for the Department of Pediatrics is social determinants of health, population and public health. I want to be clear that the specific ask from the medical school are being met within our didactics, our case discussions, our specific activities that we've designed. So we've added in HSS-specific activity in which the student is asked to pick a case from anywhere that they have actually rotated on in pediatrics, inpatient, outpatient, specialty, nursery, identify some of the social determinants of health within that case, discuss how it has impacted the patient's presentation or outcome or management, and then use a little wider lens and the literature and research to talk about one of the factors. So, you know, how did health literacy, how did ACEs factor in, how may it factor in? We don't need you to do lectures on this. You don't have to think that I need to go out and learn something else or pull papers to do it. We want you to do exactly what you have been doing, you, the faculty, you, the residents, and which is hands-on, immersive, clinical experiences, but include, discuss, map, show them the challenges that you face, the good, the bad, the very, very ugly sometimes, of what healthcare actually is. But you are not asked or required to do anything beyond the clinical experiences that you're already doing. And so I'm just going to identify that a little bit with a case we labeled the intern's dilemma. So, you know, Dr. Eames is discharging from hospital after a horribly complex long-term care, a patient who was given multiple new medications, a specific diet. He needs to follow up with a doctor within 3 days and an endocrinologist within a week. However, he has a complicated medication system that has to be administered at multiple different times. He may or may not have been able to afford some of the medications, so he didn't get all his medications. It requires some competency in figuring out doses and administering the doses. He lives in a food desert. And there is no pediatric endocrinologist in this area that accepts his insurance. So the patient quickly deteriorates and is readmitted back to hospital. Does that sound like a case anybody's ever seen? Somewhat, not exactly. But what facets of health system science can you identify in this clinical case?
The healthcare structure and process is one of them.
Maybe healthcare structure and process. Were there any social factors that impacted the outcome? Yes.
Clinical informatics and health technology too, for tying the connections.
Was there some, I'm wondering about the health literacy, the literacy, and there's so many other things, access to care. And how may you avoid this for future? That's the kind of questions that we think about and that you think about organically when you're seeing your patient. And how would you sort of frame this with a learner that's involved in the case? So what things might you discuss? And it's the same things that you've already talked about. So include them. And these are, if you have this insurance, this may be a process and an issue. Do we need a PA? Do we need to get our medications received? What are some of the systems? Do you know about GoodRx? Do you know about other things that we can navigate the system so that we can meet the needs of our patients? And these are some of our challenges that we face. And the other one was just focusing on EMR. Every one of us in here, I bet, has spent way too much time on EMR and wondered, if we're living more of our lives with the computer than with our families. Did we sign up to be typists or did we sign up to be doctors? Does it affect the patient experience? When we spend more time checking boxes on EMR and documentation than with our actual patients. But on the flip side, your patient comes to you, outpatient or inpatient, no records, very scanty recollection of their past medical history, that they've been hospitalized, and literally with the click of a button now, we can reconcile vaccines from anywhere in the state, we can reconcile medications, we can access their records from not all, but multiple other sites within Virginia. So that's a win for technology. It's not always a win, but it helps. It's certainly better than in the past. And so, what are some of the, again, you just think with a broad lens, what are some of the system issues within this example? How might a care team approach help with documentation? What are some strategies? Students are not to be used as scribes, but they may be involved in documentation of the patient, and that may be one way that you can overcome that issue. And so where are we going with our future direction? So of course, it's a relatively new conceptual model. So much remains to be done with our students or trainees in order to ingrain this within the structure that we have been exposed to. And it requires curricular content and development. It requires a lot of hands-on experience at all levels of their training and for their assessment to see effectiveness. And ultimately, they envision that this will become the third pillar across all medical schools, allopathic and osteopathic, and continuing into professional education. It will be hopefully introduced within all examinations that we take, which may promote some buy-in from students and or physicians. And they're really anticipated as a continuum across the educational spectrum, not just in undergraduate medical education, but into the GMU world and into independent practice. And of course, lots of research is needed to look at the impact and efficacy of training long-term. So the takeaway slide is we have introduced it into our curriculum. VTCSOM is one of the schools that has added this in, and this is their first cohort that we are clinically seeing. You do have expertise. This is what we do on a daily basis. And if you don't feel like you have an expertise in a particular subject matter, look around you. You are not the only experts. This is where your team approach comes in. It's your pharmacists. It's your EPIC super users. It's your nurses. It's your care coordinators. It's your social workers. Those are your team of experts. Map just individually and label current activities and skills that you have or that you utilize on a daily basis in patient care and model that within your own clinical learning environment for our learners. And at the end of the day, what we need is hands-on experience. They've got the book learning, so to speak, already. This is the actual clinical exposure that is needed for them to be clinical leaders in the future. All right, thank you. These are some resources. The Teach Academy from our school has done a really good job over the last, I think, 3 to 4 years in terms of preparing us for the introduction of health system sciences, and all of their past presentations are curated that you have access to. The AMA has a lot of resources and modules, very simple individual topics that they talk about, as well as the bigger picture. We've got textbooks and review textbooks that are out there that you have access to through the libraries if you want to educate yourselves a little bit more. But thank you. Do you have any questions?
This isn't a question, it's more of a comment or just reflection. So I'm thinking of the health system science, which is a big trend or, concern. I'm thinking of wellness, and I think about physicians. And part of this is reflecting on some of the things I've been doing recently, and the changes in the world. So I'll give you an example. Walked in to do a school physical on a 13-year-old, and as soon as I walked in, that was what they were there for. They were just there to get their paper signed so they go to school. Walk in, her BMI is so far off the charts it can't be graphed. I'm starting to think she's at risk for fatty liver, she's at risk for diabetes, she as I did the exam, PCOS, hypertension, just the list went on, and they were oblivious to that. And so from a wellness perspective, I'm overwhelmed at this point. I'm understanding this, I affect about 10% of this child's health. The other 90% is her environment, there was a language barrier, so in my, 30 years ago, I didn't confront this kind of stuff. So I think this is all appropriate, and I think you're right, it's what we've done, but I felt very impotent to make those changes. And I think one thing that is missing in this discussion, there's a piece that the patient's got to be responsible or be motivated. So how do we teach, or how do we get people to be motivated to make these changes? Because that family, they were oblivious. So maybe that's a question, maybe it's a comment, but it affected my job satisfaction that day.
I think we deal with that on a daily basis, and sometimes you need to focus on one thing and then bring them back, connect them to other resources so that the needs are being met, and what led to this ultimate outcome are being addressed on not just an individual level, but on a bigger picture level, so by involvement. Okay, any other questions? Are you scratching your head? That's okay. Okay. All right, well, thank you so much for your time.
You just gave me a new nightmare for tonight.
And stuff with sleep apnea, I didn't put that. It just goes on.